Welcome, everybody. This is the Psychedelic Support Speaker Series. I'm your host, Dr. Allison Fiducia. And today we're really excited to have a topic I know that is on a lot of people's mind, and this is how to start a psychedelic therapy practice. And whether you already run a clinic or just curious about what this might all entail, we're going to cover lots of great information and considerations for using psychedelic substances and inducing unordinary states of consciousness. And so today, our guest, I will be introducing them. We're going to have a presentation for about 45 minutes. There will be time at the end for question and answer. You can drop your questions in as we go, and I will launch them towards the end. You can also share information where you're calling in from in the chat. We do intend for this to be a way for you all to connect, for us to share information, to get to know each other better. And without further ado, I'm going to introduce our special guest. Today, we have Keith Kurlander, who's a licensed professional counselor, and Dr. Will Derveer, who's a psychiatrist, who I had the pleasure of meeting back in 2015 when he was working on MAPS MDMA studies for PTSD. And together, Keith and Will co-founded the Integrative Psychiatric Center in Boulder, Colorado, where they provide integrative psychiatric services, including ketamine-assisted therapy. They also co-founded the Integrative Psychiatric Institute, which trains clinicians on psychedelic-assisted therapies. And IPI offers this full-year online certificate training program. I highly suggest you check this out if you're a mental health professional interested in receiving a comprehensive training. It's the only training program right now that we are promoting at Psychedelic Support because of the high-quality curriculum, speakers, and instructors, and also because IPI is collaborating closely with the drug sponsors, MAPS and USONA. And so this is the only program right now that we're helping to support outreach for, because we really hope to see more clinicians getting trained in preparation for these substances to become FDA approved. And also the training includes ketamine, and we'll hear more about that too from Keith and Will. I'll be dropping in all the links in just a second so you can find out more information if you want to learn more and schedule a call there. They also host a podcast. It's called the Higher Practice Podcast. So you can tune in there and learn more about what they're up to and their special guests that they bring onto their show. Okay, so with that, I'll hand it over and we'll listen to a presentation for about 45 minutes. Thanks, everybody, for being here.
Thank you. Thanks. Hi, everybody. Let me just get my screen share going. Okay. Looks good? Will, looks good?
Looks good, Keith.
Okay. Let me just, I'll start by just talking about you and I, Will, for a couple minutes, just to bring people into our world a little bit more and why we're giving this talk. So Will and I have known each other for a long time, I don't know, 15 years plus now. Very close friends, very close colleagues prior to the Institute and the center. Will and I, about 4.5 years ago, had a similar movement inside of ourselves of that we really wanted to help be a voice and help grow a community that would change the conversation in mental health care. We were both feeling similarly that there's not enough good integrative holistic training of what root causes of mental health issues are. And we felt like it was time to try and grow a community to help change that conversation. And in that, of course, is psychedelic therapy in terms of treating root causes and promoting real change in people's lives. So prior to these two institute clinics, I was mostly where I was having experience with clients, it was through integration. I had done a lot of integration work. It was just sort of a natural thing. People found me 15 years ago, they were finding me for integration. And it was just something I sort of fell into and had a kind of personal interest in. and then I'll let you kind of introduce yourself. Will had already been involved with MAPS, and then you were starting a ketamine clinic, and so we have we've had a lot of conversations about psychedelic therapy and psychedelic therapy practices over the years, and obviously being so involved in creating curriculum for what to help produce psychedelic therapists. And so we've had a lot of conversations, and we're going to talk a little bit about these conversations today, essentially, and what we know and what we think and that kind of stuff, and love to hear questions. But Will, do you want to say a little bit more about yourself, and then I can dive into the talk?
Sure. Sounds good, Guy. Thank you. How's my audio?
Good.
Are we good? Great.
You're good.
So thanks everyone for coming. It's really a pleasure to be here, and so appreciate Psychedelic Support and what Ali is up to here in spreading really good information for people, helping people get started, get introduced to the community. And I want to also just say is when I met Ali Fiducia back in 2015 with MAPS, it was such a fun moment for me because as a Southerner, it wasn't common at that time to meet another Southerner who was involved in psychedelic research. So now we have a much wider diaspora of research going on. For example, in my home state of Alabama, and even in Louisiana, I think there are things happening there. Ali could speak to that. But the journey as a psychiatrist over the last 20 years has really been quite incredible in the last 10 years, really. I mean, as Keith mentioned, we've been looking at how to get after root causes of the kinds of really intense conditions that people show up with at a psychiatric practice for many years. And for me, it started with integrative medicine and trying to look for gut-brain problems and inflammation issues, chronic infections, brain inflammation from mycotoxin exposure, all kinds of different root causes on the medical side. And then, of course, lifestyle medicine. But what came into my focus really was around 2005, 2006, was I started to get involved in looking at trauma a little more closely as a root cause in psychiatry. And I think we all probably can agree that traditional psychiatry under-recognizes the role of trauma in the causes of chronic depression, chronic PTSD, chronic anxiety disorders. I was taught that PTSD was the only place where trauma existed, but come to find out that when we effectively resolve trauma in a person whose initial presentation might be panic disorder or generalized anxiety or even OCD sometimes. I'm not here to say that every disorder or every presentation is trauma and only trauma. We look at the broad picture and how we assess people. But the point is that I came around to understanding that trauma was really the elephant in the room in psychiatry. And as much as I worked with integrative medicine over the years, I came to find out that those of us who were in the movement, I would say, of integrative medicine in a really deep way, tended to still miss trauma too often. And so beginning to pay attention to trauma and getting trained in somatic experiencing with Peter Levine and going deep in that world, I saw really incredible results happening with people. But before I got involved with MAPS, I was still having a tremendous number of people who remained in treatment resistance and who, no matter how hard they worked in ordinary consciousness, in, routine therapies and medications and both together, could be stuck for years in treatment resistance. So it was a real game changer for me when I got involved with MAPS, and it was such a huge blessing to be invited and get involved and learn about MDMA therapy. But there was also a result of getting involved in MAPS and MDMA therapy that was unforeseen, which is that it really, it was very confronting as a practitioner when I realized that with non-ordinary states of consciousness, we could In many cases, I saw people in the MDMA assisted therapy study we did get well and have their PTSD resolved within a few months. And some of these people in our study here in Boulder, phase 2 study, were people I'd treated for many, many years without a whole lot of result to show for it. So that kind of crushed my ordinary consciousness psychotherapy practice and led me into, okay, what's next? And so in 2017, got involved with ketamine therapy, and everything started to unfold from there that we're going to talk about today. So just wanted to give you a little context of my journey into the work.
All right. Should I get in here?
Let's do it.
All right. So this conversation today is about starting a psychedelic therapy practice. This is for therapists, this conversation, in terms of, we won't be talking about underground work. And then I'll also mention some things about Oregon and psilocybin services in this conversation and how we're not necessarily focusing too much on that. So this is a conversation about a practice for therapists and then or medical providers that do therapy. And then so we'll focus predominantly on ketamine, and I'll explain a little bit more about that. Okay, so let me do a quick outline of what we'll cover today. Obviously, we could talk for hours about psychedelic therapy practices and the nuances of what to know, and there's a lot there. We'll go. I'll start us off briefly with just the landscape of the legality of psychedelic therapy for therapists and what to know there. And then we'll go into some medical safety questions about therapists and therapist offices doing ketamine therapy specifically. We'll talk about the differences between role of prescribers and role of therapists in that process. We can mention Spravato. I saw a question in there, so we can talk about that in route of administration. We'll go a little over insurance and the landscape of insurance and how that's going to be utilized, or can be or can't be, with ketamine therapy specifically for right now. Talk a little bit about advertising. There's a couple things to know about advertising, particularly on Google, that I want to cover. And then we'll go into more about setting and ethics, and just some brief overview of some paperwork stuff. So starting with landscape. So I think the first sort of broad thing that many of you probably know is that in the United States right now, when we talk about psychedelic therapy for therapists, outside of Oregon for the moment, right now, if you want to do psychedelic therapy as a therapist, the only legal substance that's not a Schedule I substance that could be done with is ketamine. And then that if it is done with ketamine is being used off-label for therapy. Ketamine does not have an indication in the FDA that you can do psychotherapy with it. So there's something called off-label use with medications in general that happens a lot in psychiatry, off-label use with medications, where the drug went through trials and there was a specific indication that was being researched for the medication. And so ketamine, generically now for many years, wasn't originally researched for indications for mental health. The exception now, which somebody mentioned, is Spravato, recently did get an approval, which is a form of ketamine, for a couple indications, not psychotherapy, but for depression and a couple other things. And Will can mention that when we go over route of administration. So ketamine is the medicine that could be used off-label in a psychedelic-assisted therapy setting. Now coming January 1st, there will be a caveat to that, which is that Oregon psilocybin services, assuming they meet all their deadlines, and we're in very close contact with them, they probably will, is that in Oregon, we will see Oregon psilocybin services. That is not a medical model, meaning that it wasn't designed to be only practiced by psychotherapists or for it to be a psychotherapy service. So it's just good to note that in Oregon, psilocybin under the rules is not a psychotherapy service. So therefore, we won't even get into that. And the other thing to note is psilocybin is still a Schedule I substance, as well as cannabis. Some people are doing high-dose cannabis for what is called psychedelic therapy. And I've heard stories that it's very positive for some people. That is also a Schedule I substance in the United States. So, so we'll kind of wrap there of like, we'll just focus on the substance that off-label could be used in a psychotherapy setting legally right now. Okay. And just please, as I go along, put questions into the Q&A so you don't forget them. If like you had a question about the legality or something, throw it in the Q&A and we'll come back to it at the end.
Let me, can I just
yeah.
add something about the landscape,
Sure.
Keith?
Yeah.
So bearing in mind that most of our listeners today are therapists, there are a few prescribers who are coming in the chat. So I just want to mention for the prescribers there that when we talk about off-label use, we need to think about what is the evidence base that we are justifying our treatment from. So when we have an FDA-approved medicine and we're using it, so to speak, on label, so there is an FDA indication, like with Spravato for chronic depression, we don't really need to worry about the DEA knocking on our door and saying, why are you treating this person with ketamine in the case of Spravato? But when we're using generic ketamine, the kind of ketamine that was approved in 1970 that, you know, costs about $5 a dose, we need to think about what studies have been done for the types of suffering that we're treating with that ketamine. And I think the reason I'm mentioning this is that this is maybe a longer conversation for another presentation, but within the different routes of administration for ketamine, there's a wide range of different qualities of evidence base to pull from. When the Berman paper came out in 2000, and then that was followed with research on generic ketamine at NIMH, a big study came out in 2006 that Carlos Zarate published about IV ketamine. Up until a year or two ago, almost all of the evidence base for generic ketamine was IV. And that's still true today. There are, in the last couple of years, a little bit more evidence, a very small handful of studies on sublingual ketamine with psychotherapy and intramuscular ketamine with psychotherapy. But by and large, when we're talking about relying on an evidence base to treat someone for depression, PTSD, OCD, we have a lot more evidence for IV ketamine. And that's why I think we just need to be mindful about how we're going about talking about what we're doing and justifying it in case there's a question about why you're using ketamine the way you are.
Thanks, Will. So that goes into roles, and I'm glad you brought this in now, Will. So one thing to understand as a therapist who wants to do psychedelic therapy with ketamine, and we'll go into how that would look, is that the indication is still a mental health disorder. Medical provider really needs a mental health disorder that they can stand behind, that's been researched, that ketamine helps. Depression is the most researched. Treatment-resistant depression is the most researched. So there hasn't been a lot of studies on the psychotherapy aspect of using ketamine. So it is important to understand that when we're doing psychedelic therapy with a client with ketamine, that likely the research shows the ketamine is probably going to help them whether you do the psychedelic therapy or not for depression. a lot of the research shows that we don't have good studies yet to differentiate out how much does the therapy help. And so it's just important to know that, that the clients, what we're going to talk about today, we just conservatively take more of a research-backed perspective on how we talk about things. So we'll be talking about today about the indications, about what type of clients are a good fit or not. And that we believe we are very strong proponents of always having psychedelic therapy with a psychedelic. And we'll talk about that. So what are the roles, with all of that said, what are the roles here of doing psychedelic therapy in a therapist's office with ketamine? So one role is the medical prescriber, right? So the client needs to get the medicine. The therapist is not giving medicine. They're not administering medicine. The client needs to get medication because their health issue, their mental health issue warrants the ketamine treatment. So that's the role of the medical prescriber. That is either a physician or nurse practitioner, that could be a physician's assistant that's prescribing the ketamine to the client. Typically, how that works as a therapist is there's a relationship that was built in your community, is typically how it works, with either a physician or a nurse practitioner. And the therapist is typically who has a psychedelic therapy practice, typically referring clients to the nurse practitioner or physician because they need an intervention with ketamine. Then the medical provider sees them, does their consult, feels that this person would benefit from a ketamine treatment or a series of treatments, prescribes them the ketamine. They get the ketamine delivered to their home usually, and then the client brings their ketamine into the office, and it's sort of viewed as like it's a benefit that the therapist is there and everything, but you're not a medical provider in that moment as a therapist. You're not overseeing the administration of ketamine. You're just doing your therapy. So an important nuance to understand so that you stay in your scope of practice as a therapist. So obviously then the therapist, their lane is doing therapy, focusing on, depending on the model, but focusing on doing integration and preparation and sitting with them during the actual session. That's the role of the therapist, is working with the therapeutic part, getting the medical prescriber involved if they need to. The medical prescriber is overseeing future dosing sessions in terms of new prescriptions. Whether or not it's actually warranted for the client is the medical provider's decision. It's just really good to wrap your head around. There's a nuance here, so you're never out of your scope of practice. Your scope of practice as a therapist with a psychedelic therapy practice is really you're doing therapy, and that's what you're up to. Now, there are, of course, situations where the therapist is also a medical provider. We won't go into that nuance, but that happens all the time. Psychiatrists, psychiatric nurse practitioners doing therapy, then they're doing it all. So, whoops, I went the wrong way. Okay, one last piece to say about route of administration. Now, when therapists are alone in their office with the client and there's no medical provider on site, the safe way to do that is it's sublingual ketamine. The client is not giving themselves their own injections of IM or whatever else would be done. It's sublingual ketamine at this point that's being done in that type of setting. And we'll talk a little bit more about routes of administration. So why don't, Will, you take it from here about routes of administration and medical safety?
Sure. And another nuance to add to what you were just saying, in the setting where you're a therapist and you're in your own clinic with your client and there's no medical personnel on site, remember that a best practice is for your client who was prescribed ketamine by the medical provider to self-administer the sublingual ketamine. So it's might seem subtle, but if you are putting that sublingual tablet in the mouth of your client, it's not a great idea because that could be looked at as the practice of medicine. So the way it would work, and not to belabor the point, but the prescriber would tell the client, here's a dose of sublingual ketamine, here's how you use it, here's how you administer it to yourself. And you're going to face questions, I guarantee you, if you get in this work, where the client says, okay, I took my lozenge and nothing's happening, so what do I do next? And again, another moment for the delicate balance of supporting your client but not stepping into practicing medicine. It would not be a good idea to say, well, I think you should take another one, because what the dose is of the ketamine for that particular session is a prescription that the conversation needed to happen with the prescriber. So it's the prescriber's responsibility to tell the client what to do with the troche or the ODT if the first dose didn't produce an effect, and the person may want to take another dose. So
Yeah, thanks for saying that one, because there was a question in the Q&A. And again, it's delicate. It's not like you would just be like, I'm not allowed to say a word. Like, obviously,
Yeah.
you're not going to be aggressive and just be silent. But it's delicate. And in our clinic here, where we do a model with IV, with therapists, we're very careful about the therapist getting involved with saying you should increase your dose. That is actually, that right there is a medical advice. So it's just delicate. You need to tread very lightly around this issue. That's all we're trying to communicate.
Right. So the pro tip here is for your client to already know what to do through their conversation with the prescriber in the event that they may take a second dose or a booster dose during the session. So that's already been covered. So you're not out on a limb with your client in that moment.
Right.
So
now there is one more thing here, Will, that is important. Right now, we're mostly focusing on a therapist practice where a medical provider is not present. It's a whole different conversation if you're in a clinic model and there's a medical provider there. So we're not going to focus on that, just because that's a different model. For this conversation today, it's how does a therapist start a psychedelic therapy practice without a medical provider present?
Right. So let's talk about vital signs a little bit. So ketamine, whether it's sublingual or IM or IV, produces a blood pressure increase of about 10 points and a pulse increase of about 10 points. These are averages for about 30 or 40 minutes. And so that level of blood pressure and heart rate increase is something like taking a brisk walk for 30 to 40 minutes. So there are people who, when you start screening for blood pressure as a medical provider, it's astonishing how many people are walking around with high blood pressure because it doesn't cause any symptoms typically that hasn't been addressed. So it's important to know what the risks are. And really the only way to know what the risks are is to have some data to hang your hat on. So the medical provider, in my opinion, should be looking at a resting blood pressure to see what it is. Another piece that we feel is important is looking at pulse oximetry, because, and this is really maybe you could say on the conservative end of the spectrum, where we feel that we want to know what the pulse oximetry rating is, because there's a very rare side effect of ketamine. And when I say very rare, I'm talking about like 1 in 100,000 doses of ketamine, where a person can get a little spasm in their airway. It's called laryngospasm. And the first sign of trouble with the airway with ketamine is a drop in the pulse oximetry. So in our practice, we've now been doing ketamine for almost 6 years now. We've only seen 1 or 2 drops in pulse oximetry to the point where we got concerned and put oxygen on somebody. Now, I'm not saying this to scare anyone. And, as a physician and bearing the responsibility to provide safe experiences for people, I might be more conservative than a therapist. I don't know, but I feel like it's a good insurance policy to have that pulse oximeter on the finger of the client. And this is something that therapists can do. And there are therapists who do have pulse oximeters in their office. And this would be another delicate conversation where the prescriber that you're working with, your partner in ketamine therapy, can say to the client in the medical consult, you're going to wear a pulse oximeter in the therapist's office, and you'll put it on your finger. The client will put it on their own finger, and the therapist, if the alarm goes off, can, reach out to the medical provider. Again, on the conservative end of the spectrum in terms of monitoring and safety. I think that the next point, basic life support, another name for BLS is CPR. So knowing how to get your CPR training is important. It's really easy to do. You can do it online. The American Red Cross has a course that I did recently for $40 online. Took me about 2 hours to finish it. So having that certification, I think, is a really good protection for the client and for you. Hopefully you'll never use it, but having that certification active is a good protection for you from a liability standpoint as well. And we've talked about scope of practice in terms of staying in your own lane. And then at our clinic, we like to do a set of vitals before and after and make sure we get a good sense of the person's mental status, including their gait, before they are medically discharged from our clinic.
And vitals in practice doing sublingual therapy in a therapist's office without a medical provider. Again, this is delicate, as Will said, because what you don't want to do as a therapist is be in the role of interpreting vitals and what to do about that. So this is something you would work out with your medical provider. And if they want to use vitals, what is it that they want to have happen with the client? This is really about between the medical provider and the client. But it is your role to never let a human being out of your office with a severe altered mental status. That's actually your role, whether they are on ketamine or not. So it just flows into ketamine. You shouldn't be sending people out into the world and they've got a very altered mental status and they can't take care of themselves. So that's a part of the discharge process as a therapist. You want to make sure they can walk okay and that their mental status is, clear. Do you want to talk about time real quick, Will, with sublingual?
Oh, so thanks, Keith. And before I go to time, one more piece we didn't put on this slide deck, but it's really important, is not driving home from your ketamine-assisted therapy experience. This is a really important safety factor. And so it's important to have a really strong agreement with your client and also have a good plan for how they're going to get home. And then time is, the therapists I know who are working with sublingual ketamine, generally, it seems like most of them are scheduling a 3-hour time block for their sessions. And this is a bit longer than what we do in our clinic with IV ketamine. We have 2-hour sessions for ketamine therapy, ketamine-assisted psychotherapy. But when you're working with sublingual, the fact that your client is going to swallow some ketamine is going to lead to some metabolites that can cause nausea and unsteady gait to last a little bit longer than it would with IM or IV. So sometimes people feel a little seasick or kind of unsteady on their feet for up to 2.5 hours after taking a sublingual dose of ketamine. So it's important to have enough time in your schedule to accommodate these kinds of issues.
Right. I'm going to say one last thing. We'll go to the next slide, which is we get questions all the time from new students applying to our programs and other places of, am I in my scope of practice as a therapist to do this? The answer is, I don't know. What I do know is that the boards, you're not going to go find language likely at this point in any state. Maybe one state have done it, where there's actually language about ketamine-assisted therapy on a psychotherapy board's rule sets. Maybe someone's taken a position. Sometimes your association has taken a position, but mostly there are not stated positions. So what I like to say when someone says, am I in my scope of practice? There's a few things that you must address, and I'll speak to it real quickly now. One is you want to make sure your liability insurance is behind you. And I'll talk more about that in a little bit.
Would that be better? Should people ask before or after the ketamine session?
Well, I'll talk more about that in a little bit. And then the other piece, you just want to really know that you're taking scope of practice seriously as a therapist, and you believe you're in your scope. You need to ask the question, is really how I answer it. You want to be asking the question, am I in my scope of practice? Because 9 times out of 10, you'll know if you're out of your scope of practice. Like you're like, oh, I'm doing this medical thing, and and you really just want to be asking the question to make sure you're doing everything you can to really believe you're in your scope of practice. You're getting good education. That's the last thing I'll say, which is that if you don't have extensive education on psychedelic therapy, you're not in your scope of practice. You're practicing a modality that's not in your scope. And that's why in disclosure statements as therapists, you need to disclose the training behind the modality you're doing. So if you haven't done extensive training, and I mean more than like 6 hours, you're not in your scope. So it's important to know that you need extensive training to practice this modality, to stay in scope of practice as a therapist. Okay, insurance. I'll just keep going here. So insurance it's very important to contact your liability insurance. You don't want to be doing things as a therapist where you feel like you need to hide it. If you feel like you need to hide it from the liability insurance as a therapist, then you're already sort of setting yourself up for an issue, right? So it's always good to contact your liability insurance carrier and say, I'm doing ketamine-assisted, I'm going to do ketamine-assisted psychotherapy, if you haven't called them or if you are, and say, is that, am I covered in my scope of practice with you? Most liability insurance companies won't give you a definitive answer, unfortunately, is my experience, where they'll just put it right back on you and say, as long as you're within your scope of practice, you're covered. Okay, some will actually come back and say, we do not cover ketamine-assisted therapy. So when that happens, I highly recommend you go get another insurance carrier that's not saying that to you. So that's just something to really think about. That is one of the first places to go. If you're in a state where people aren't doing this very often, I also recommend you contact your board and say, I'm going to be doing, ketamine-assisted therapy. Has this board taken a position on that? That's what you're asking them. Have they taken a position on it? And they'll let you know if they've taken a position on it. If they come back and I haven't heard this, but if one of the boards has come back and says, we took a position and you can't do that, then you're out of your scope. But I haven't heard that yet, that a board has taken that position, but you should call and contact them. Okay. Let's say a little bit about advertising. So here's the thing to know about advertising. One thing is that when we talk about what we're doing as therapists in the community, it's important we talk about things where people understand what we're doing, and there's not a ton of room for speculation or assumption that we're doing something illegal. There have been many therapists, I've known some that were doing underground work and they're free to talk about it, and they've got in trouble with their boards. And so with ketamine-assisted therapy, it's just important that, you speak about it in a way that's legitimizing the practice, and you're not, doing it in some haphazard way where you're like, on Instagram, you're saying, hey, anybody that wants a ketamine assisted therapy session, come to me. Anybody's welcome. That's not an indication based model. And that can get you into trouble. So it's just really important to be mindful of how we talk and what we say, particularly as a licensed therapist, since there's boards sort of watching us. And then from a more technical perspective, if you choose to want to advertise your practice in Google Ads, in order to advertise in Google Ads anywhere with the word ketamine, anywhere on your website, there's something to just know, which is you will need something called legit script certification. Legit Scripts is a third party that authorizes people in Google to advertise protected terminology. And the reason ketamine is flagged is it's a protected term. And the one area you would be allowed to advertise is if for some reason you do any form of addiction treatment, you're eligible to get a legit script certification, which would allow you then to advertise in Google Ads. Something to know if you really want to use the Google Ad thing. Facebook and Instagram have not yet had those guidelines with ketamine. That might change. So we'll leave it at that. Will, why don't you take over set and setting? It's 12:40, Will. So maybe
Great.
we
Thanks,
have about
Keith.
5 to 7 minutes and we should wrap up.
Sounds good. So I saw Scott was in the chat talking about how he mentioned set and setting and research. And I just want to underline his comment that set and setting is critical. As Keith put in this bullet, the first bullet here, that we used to be in a clinic setting that had a kind of like a fitness center or something underneath us. And there was loud music and people grunting and lifting weights and things. This was a group that moved in after we had been there for a few years, and it was really super problematic for our clients. So we ended up having to leave, and we're glad that we did. Now we are in a setting that is beautiful and rural, and we're on the ground. So there's nobody underneath us anymore, which is huge. So set and setting is something you can certainly read about, and something we train people heavily in our trainings. And I would just say that for me, set and setting is as important as the chemical. It's really important to attend to having a safe and quiet and supportive space. And part of the set and setting is the place that your client is going to sit. So just be aware that, when people are doing somatic release or they're moving through things, moving things in their body, they might writhe around, they might move, and they can fall out of chairs and they can fall off of couches. So just bear in mind that the seating is important. We use recliners that have high armrests, so it kind of keeps people where they need to be to do the work. And stairs are difficult. We would not recommend that. We also had a staircase that was difficult for us to get people out to their rides in the parking lot previously. So anything you can do to make people comfortable, and also to weave in the other background and training that you have in supporting clients to feel really safe and secure in the environment.
You want me to take this, Will?
Sure, go ahead.
Well, legally, I would just say, legal matters. I just always recommend not taking this too casually if you're going to get involved in this work, and you're new to it. I think it's important you have mental health lawyers involved in the mental health space that are working with you on your paperwork, reviewing your paperwork. There's consents that need to have happen. I think it's just important that you make sure that you are delivering material to people that's accurate when it comes to the way things need to be written, and that you have good counsel about these things. So having a lawyer on your side to run things by, especially when getting set up, I think is very important. One thing about video monitoring. So in research, video recording equipment's used for sessions. It looks like Oregon psilocybin services is going in the same direction. The final rule set for service centers and facilitators hasn't been issued yet, but it looks like they're going in the same direction, which is you need to be doing video recording of sessions. We do video recording of sessions in our clinic. We recommend video recording. People in altered states can have experiences where they can say something happened and you're clear it didn't. And the only way you would ever really be able to go back and show the person it didn't happen would be a video. So we do recommend video recording. We believe it provides more safety to the set and setting of the client, that, you know, it's more of a safety thing, and that it's not accessed unless there's an issue. So I'll just leave it there. Okay, therapeutic touch. Do you want to end just with a few comments on therapeutic touch?
Sure, and then we'll get into the Q&A. I want to make sure we have plenty of time for that. So therapeutic touch is a sensitive issue, and the way Keith and I feel about it is that there are situations where therapeutic touch is not a good idea, and situations where failing to provide therapeutic touch can be a huge injury in the alliance between a therapist and client. So therapeutic touch is a whole, again, like a whole rabbit hole to go down in terms of how to do that really skillfully. And again, I would not recommend it without training. But therapeutic touch, it's important. What we want to say here is that it's important to get consent about agreements about therapeutic touch before the person is on ketamine, because once they're in an altered state, they're not in a position to consent anymore. And we strongly recommend that you follow the agreement that you made prior to ketamine, even if the person on ketamine is saying they've changed their mind. So talking about what happens if they change their mind before they go on ketamine is another pro tip here. And then with regard to training, again, Keith mentioned this earlier, but it's really important from a risk management standpoint, and also just from having a level of confidence to be doing what you're doing, that you have good training in what you're doing. It would be just, think about EMDR or CBT or DBT. You're going to want to get training to be able to feel really confident in it. And the thing about psychedelic therapy is it's actually quite different from doing therapy in ordinary consciousness. And there's quite a bit more to learn, just speaking from experience and having to unlearn a lot of things that I was taught about how to work with people in ordinary consciousness. It's not a quick sort of wing it and start doing it kind of situation.
Great. Well, let me just say one more thing, and then we're going to go to Q&A about video recording. Somebody mentioned that Oregon has said you can only do video recording with written consent. You can only do video recording with written consent. That is clear. Do not record people and they don't know about it or they have not consented. And it's unclear where Oregon will lie in their final rule set about whether or not you're allowed to proceed if you don't get written consent, whether they're saying that's a requirement or not. I'm not sure. I haven't looked at the rule set in the last couple of weeks. It keeps changing. But in general, we don't come across people choosing not to give written consent. If we did in the clinic, someone said, I don't want to be recorded, we would meet as a team and discuss whether we're willing to proceed. That's what would happen here. So just something to consider. Okay, let's go to Q&A.
All right. Thanks so much for this presentation. It There's lots of questions coming in, and I flagged a few to start with, but you all can look as well and see what you might want to answer on this topic. But one that comes to mind is for those that are thinking about psilocybin or MDMA, as this may be approved in the coming years, how might you see the practice of delivery be similar or different to what you're doing with ketamine?
Well, I think the really short answer is we don't know what the practice will be with MDMA. Let's start with MDMA. Psilocybin, from FDA trials perspective, is later than MDMA. I think the real answer is we don't ultimately know yet what the safety protocols will be on MDMA. I don't know if you want to add anything, Will, in terms of speculation of what you think they'll be, but.
Well, I was going to interpret the question from a different angle and say that I think the experience of providing ketamine-assisted therapy can be a very nice way in to these medicines in general, in terms of what's coming later, or what we hope is coming later with FDA approvals. The method that we use, that we teach our therapists to use, is informed by, Ali mentioned this earlier, the work being done at MAPS and USONA. And I think that the procedures of ketamine-assisted therapy are shorter because the effect of the medicine is way shorter than MDMA and psilocybin. But in terms of the practical considerations of what it looks like and feels like in the room to be a therapist with these medicines is pretty similar.
Great. Yeah, I'll just add to that. The FDA is going to work with the drug sponsors to develop a risk evaluation and mitigation strategy, which will outline all of these requirements. So if you look at Spravato, you can see some of the REMS included staying in a clinic with medical providers for 2 hours during the administration, and some stipulations like that. So that's why there's a lot of open questions around what will actually happen with MDMA and psilocybin.
Yeah.
The next question, we mentioned the video recording, and I think these are really relevant questions about what type of setup and how do you store these videos, because it could end up being a lot of files and storage requirements around this.
We lean toward, you can do this in a lot of ways. We lean toward a closed network is how we talk about it, doing a closed network, meaning that you can't access it if you're not on site through the internet. That would be a closed network. There are video recording systems out there in terms of having closed network and actually locking these encrypted drives behind closed doors. Nobody could do anything with it if they got the drive. So what we recommend is a closed video recording network system. And these are not, you can do these relatively inexpensively. There's a lot of, cheaper equipment now out there where you have a camera and it sends a line into the system. And then it's, behind a lock and key. And the only way to access it is on site with your own encrypted password entry. I think that's the best way to say it. I would not get too careless here. Sorry, I'm getting over COVID. My chest kicks in every once in a while. I just wouldn't get too careless of like having some random videos lying around or anything like that. Something to be very careful around.
Yeah, and
but you can do it safely.
Closed system means not a cloud-based storage system.
Yeah,
just to be clear.
We don't do cloud-based just because that can be accessed from anywhere in the world. So we don't do that. We recommend a closed system that you can't access without being on site where the drive is.
Great. So we have some questions about individuals that are interested in pursuing training for psychedelic therapy. So they are wondering about your training program. And specifically, there's a question from a naturopathic physician and if this would be appropriate training for them.
Well, we have some naturopathic physicians. Our training is a comprehensive training, meaning that our training's a year long, and we really wanted to focus on training a full modality versus like working with one medicine and something like that. So Our training is like a modality-based training, which takes time to learn a modality in therapy. So we cover the 3 medicines that are likely going to be accessible. So ketamine, MDMA, and psilocybin. We go very deep into all those 3 medicines. It's a professional-based training. So we work with therapists and medical providers. For medical providers, like a naturopath, you have to just demonstrate you've had 1,000 hours of behavioral health contact hours so that you have a background in counseling. Because our training is essentially an advanced training of psychotherapy. So you need basic psychotherapy skills.
Okay, great. Let's see, I can pick another question, or if there's something that you all saw that you want to answer, you can just hop in.
You can go for it.
Let's see.
This is kind of a related question. It's from a psychiatrist who's asking about residency programs that are involved in psychedelic therapy.
Yeah, that's a great question. I mean, now we have a number of academic centers. Ali put in University of Alabama at Birmingham is one place that's happening. Obviously, NYU, Hopkins, UCLA, UCSF has a really active, thriving psychedelic program now. University of Wisconsin is very active. Where else am I leaving out, Ali?
Well, I know that there's a number of different academic institutions that are coming together to come up with a curriculum that could be employed at many different types of residency programs. And there's some funding that's been put forth to do that. And we'll see in the coming years where these will be offered, but the idea is to really start to standardize some of the material, have a lot more places for access, and this to become something that is typical and conventional for residents to have this type of training or exposure to psychedelic therapies. And along that line too, someone is asking about CEs and CEUs for the IPI training. I know that this is offered continuing medical education credits and CE units for therapists.
Correction. It is not offered for continuing medical education credits. It is offered for continuing education credits through the American Psychological Association through a joint providership. We offer the most CE credits. I think we have 80 credits. So that usually covers people for many years, multiple years. We do not have CME for the program. Our provider is the University of Colorado, and they take the position that let's wait for MDMA. That's their position, basically. So it'll probably be for CME if MDMA gets approved.
Right. So we went through the process to get some of our self-paced on-demand courses approved for CME if anybody's interested. And, initially when we applied, they thought, no way, the doctor review board is not going to approve MDMA and psilocybin CME courses. And in the end, they did, which was really exciting. And we actually got a flattering recommendation for the courses that the doctors really enjoyed the content and thought it was really important for this research information, best practices around harm reduction to be provided to medical professionals. So it's great to see the tide starting to shift from some of the more traditional boards and reviews to have more acceptance around psychedelic therapies that are evidence-based.
Absolutely.
Yeah,
I will just say to the resident question, we offer residents discounts on our training. And hopefully, as you said, Ali, this initiative to get a more standardized training adapted and adopted. There's been talk of like a psychedelic psychiatry fellowship at some point, but I think that's not quite ready for prime time.
Great. So there's also a couple of questions on here. We will share the video after. And people are asking if it's possible to have your slides and your contact info, Will and Keith.
We don't generally give out our emails just because, we have thousands of, our email inboxes can get crazy. So we don't typically give out our own personal emails just because of our position. It's challenging. If you really want to reach out to us with something that's specific, I would reach out to psychedelic support, and they might forward it to us. And then, we want to connect when we can. It's just that when we give out our emails publicly anymore, it becomes a real problem for us. Our email inboxes get super crowded.
Yeah, so connect with them on LinkedIn. And I did put our info at Psychedelic Support email address in the chat, and we'll try to address any questions or help you find the answers. And I have been dropping in the link to their training. So if you're a licensed clinician and want to apply, you can get more info there. And then there's a place to schedule a call. So you'll put in a little bit of information, and then you can actually get on a call with some of the training team to, address any questions you have about the program, which is going to be starting the next cohort in January 2023. So now's the time to apply if this interests you in taking the next steps with the IPI training.
Yeah. Great.
Okay, great.
Thanks,
We're
Allie.
at the top of the hour, and I thank everybody for coming and all the questions and resources shared. We have a limited amount of time. We didn't get to everything here, but I'm very grateful for the information that Will and Keith shared with us today, and for all the other comments that in connection that went on in the chat here. It really makes these events lively and informative. And I hope to see you here next month when we'll be hosting the Plant Medicine Law Group and another attorney to kind of dig into some of these questions about insurance and liability. And this time around, we're actually taking questions ahead of time. So when you go to register, you can drop in your questions and we'll sort those prior and get the ones that everybody's asking for. So thanks so much,
Awesome.
Keith and Will.
Thanks, everybody.
Thanks,
Thank
Allie, for
you.
having us.
Thanks for having
Yeah.
us.
Thanks,
Great.
everyone.
Bye.
Bye-bye.
Bye. Take care.